Good afternoon. My name is Eugene, and today I'm going to be discussing chronic lower back pain. So moving forward to the slideshow, I'm going to present right here, as you can see. Discussion of chronic lower back pain may seem rather mundane. I think in all our practices, we see it quite often. We experience it at home with family members and such. And the question is what to do with this? Where do we start? What methodologies do we have to diagnose? And what considerations do we have to treat it? And over the discussion over the next 40 minutes, I'm going to touch upon each of these. And at the end, for about 15 minutes, we'll have time for a question and answer session too. So please feel free to write down some questions so we can discuss it at the end live as well. In my discussion today, I'm going to start with a brief history and discussion. Thereafter, discuss the epidemiology. Are there certain ages or predilections of types of people who get this? Certain causes and pathophysiology. What does cause back pain? What is the pathophysiology behind this? And thereafter to discuss how do we diagnose this? Be it the exam, various other modalities that we have to use to diagnose. Prevention of back pain. How do I prevent from having this back pain in the future or even getting it in the first place? And certainly discuss management options, of which invariably as health providers we have discussed and ponder and try to help patients with. So starting back to 1600 before Christ, the Edwin Smith Papyrus is actually the oldest known surgical treatise on trauma. And it actually discusses 48 cases of various injuries and wounds and such. And it describes a diagnostic test and treatment for vertebra, back sprain. Moving forward through history and such, moving to the Bible itself in Psalm 38, 7-9 states, "My back is filled with searing pain, and there is no health in my body. I am feeble and utterly crushed. I groan in anguish of heart. All my longings lie open before you, Lord. My sighing is not hidden from you." And moving forward again, Hippocrates in 400 BC discussed lower back pain and sciatic discomfort. And through the 500 to 1500 AD, in the medieval times, there was discussion of watchful waiting being recommended for lower back pain, and discussions of even spirits and bad spirits needing to be taken out that were purported to be the cause of this back pain. In 1920, Dr. Cushing had discussed the increased consideration and eventual acceptance of surgical treatments for lower back pain. And doctors Mixture and Barr in 1938, both orthopedic surgeons with Mass General, performed and reported cases in the New England Surgical Society of back pain improved with discectomies and surgery that they performed on patients. Lower back pain, though, who gets it? And is it as common? Is it a major concern? Well, up to 80% of all people in this world have had significant lower back pain at some point in their lives. And at this time, out of the people in our country, in our nation, up to 10% have lower back pain at any given time, which purports to about 600 million people in this world at this time. When one has lower back pain, it usually begins between ages 20 to 40, and it becomes more common as we age and get older. No doubt, you've heard that term, boy, I have these new aches and pains, I must be getting older. And I'd like to not think of it as only a sign of getting older though, and certainly there's treatment options and things that we can do to help it. But as far as global disability goes, compared to diabetes, heart disease, cancers, Alzheimer's, asthma, certainly lower back pain is at the forefront of concerns. For disability, The top 5 causes of disability include migraine, depression, skin disease, various organ diseases, but number 1 at the top of the list include, again, back and neck pain, as far as common musculoskeletal complaints seen in the ER and disability. So back pain, and focusing more on lower back pain for this discussion, is it all the same thing? How do we look at back pain and figure out what type of back pain, what kind of symptoms and considerations are made when we ask ourselves, ask our family and our patients about their back pain? So somebody comes to you with back pain, certainly some things to ask are, does your back pain worsen with certain movements? What movements? Lifting, twisting, bending, standing, sitting too long. Maybe a lack of movement is causing your back pain to worsen, perhaps. Does the back pain stay in the back itself, or does it radiate down the legs? Is there any symptoms of this neuropathic numbness and tingling? And also, ask questions of depression, anxiety. Are there any sleep issues that one is having with this back pain as well? With back pain, posture certainly is a consideration. And when you see your patient in the office, or nowadays, be it on Zoom, have them stand and take a look at their posture. Discussion of obesity, stressors, patients with back pain in their 2nd and 3rd trimesters of pregnancy, deconditioning, poor sleep positions, poor sitting positions. In this time of pandemic, with patients I've noticed sitting more in their chairs, on their videos at home, or on their couches at work, but at home sitting all the time, I've noticed a lot more patients having back pain for concern of deconditioning and poor posture and excessive sitting in bad positions that are causing their pain to worsen. And when I look at what is causing the back pain, they ask you, what is causing this back pain? What are my concerns? Is there something dangerous going on? We like to look at 4 main categories: mechanical musculoskeletal, inflammatory, some type of malignancy, looking for red flags and concerns, and infection. So when looking at regular degeneration, musculoskeletal, the most common cause, usually by your 20s and past the age of 40, is seen in active patients with mechanical position changes, considerations of muscular strain and spasms, osteoarthritis, be it a disc bulge, a nerve being pitched, after an accident, a compression fracture, narrowing of that spine. But we also look for what we call red flags, something dangerous. Is there something inflammatory going on? Is there swelling in ankylosing spondylosis, reactive arthritis, be it even infections themselves to the spine? Malignancies, be it bony metastases from the prostate, thyroid, lung, and breast cancers. Be it a weight loss, an unusual back pain that wakes one up at night from their sleep and keeps them from sleeping. And again, infections themselves, be it a bony infection, not just an inflammatory process, but a bony infection within the bone itself. Are they feverish? Was there some type of inciting infection that was treated or partially treated or not treated at all that has gone to their spine? And when we talk about the causes, certainly then we'd like to move forward to back pain itself is not just one area, many different areas, and we'd like to move to what are the considerations, the various structures involved. And certainly back pain is not just spinal cord and bone. And I'm going to speak it out on this diagrams through. Back pain can be from the neck, the middle back, the lower back, these various structures, the vertebrae that we have, the cushions that help support these vertebrae and the bodies, the vertebral bodies themselves. Certainly spinal cord and nerve injury of these wires are consideration when we ask for numbness and tingling and radiating type symptoms. but also the posterior, the dorsal structure where the facet joints rest on each other. Joint pain when we're leaning back, and we'll discuss this a little bit more in a bit. What if it's just the muscles themselves, a muscle sprain, a cramp that kind of begets itself, a myofascial injury at a trigger point that forms, or even these blood vessels that lie within the spinal area causing claudication and blood vessel abnormalities that can cause back pain. And when one sees a patient for examination, be it in person or on the video, really the first step is get a great clinical history. Discuss how it started. What are your symptoms? What do you feel makes it better or worse? Is there any infection or any cancer in your family or that you've had or you've been battling? Look through the medications and history. Was there a previous diagnosis of prostate cancer that seems in remission right now that we need to consider with the pain that the patient is not sleeping well with at all? And then we use the physical examination to determine the location of the pain generator. Again, watching for red flags of, was there an injury? Are you weak? Is there some type of nerve damage? Fevers, infection, is that connected? Unintentional weight loss. Many times in our field, we put a lot of weight on imaging, and certainly X-rays, CAT scans, MRIs, nerve conduction studies, and needle testing of the muscle to look for damage are very important in what we do in diagnosing and treating back pain. But I have to stress, even with all these studies that we can do to say, well, we're waiting on the imaging and then we'll have all the answers there, I think that's not being fair to ourselves as providers and to our patients. I firmly believe that the clinical history and examination means so much more than the image itself. The image, again, like most of our tools in medicine, are only a tool, an arm that we have to use. But the brains behind it really focus in on what we see on the clinical history and physical exam. These tools can be used, but certainly, I've seen it too many times, a normal image can occur in patients with excruciating back pain, and abnormal images can be found in areas that are not causing the pain that the patient is really having. Be it a disc bulge without radiation down the leg and a patient on clinical exam still having just more focused myofascial pain. So pain itself, when I think of pain, I like to ask a lot of the trainees, the students, the residents and fellows, oftentimes my first question is always, what is your definition of pain? What is pain? And the definition of pain I like to use is the feeling of tissue damage and the fear of that tissue damage. And the pain is perceived by this pathway. So thus, you have your foot in a big boot, a nail drives through, it doesn't touch your foot at all. But if you're feeling the pain and you're feeling the fear, that pain certainly is that patient's pain. And that pain is real to that patient because they're feeling it within their neural circuitry. So looking at the diagram here of the pain circuit, for example, a tissue injury, a tack going into the first toe on your right foot, you have the tissue injury occur, then the nerves feel this, perceive this sensation, it goes into your spinal cord, and it projects to the brain. And then the brain itself modulates its perception of this pain. And the fear, be it the amygdala and the part of the thalamus, to figure out, I feel this through my spinal thalamic tract. Now, where is it? The fear, the emotional response, and these signals then further modify it. Is it a pain that I should inhibit? Not as painful, or is it a pain that I should ramp up? So certainly pain, again, is the feeling of pain, tissue damage, and the fear of it. And when you think of someone having pain, even in the back, think of the tissue damage, or even the lack thereof, but a sensation of the pain in that area, your nerves perceiving it, being transmitted to the spinal cord, up to the brain modulating it, understanding it, and either inhibiting it and reacting to it. And that is pain. And when we think of pain in the back, at this point now, 10 minutes in the lecture, I'd like to say, and I'd like to think that now we have a good feel of the different structures that can be involved, and the fact that a lack of pathology that's obvious on an image or an obvious pathology needs to be considered, but not the end all. If there's a normal scan, you can't see anything on examination, but they're still having the pain. The pain is how the patient perceives it. They're feeling tissue damage in an area, the nerves are perceiving it, it's going up the spinal cord to their brain, and obviously the inhibition that their brain is performing on this pain is not enough. They're feeling this, and they're asking us for help. What treatment options do we have? Is it taking an Advil and going home? Well, at Loma Linda, we really like to discuss with our trainees and with our patients what we call a multidisciplinary approach, basically meaning we have a lot of things that we work together with to help you. And be it one thing may appeal to one patient more than another, and we work with that. One treatment and a combination of may help one lady, but not as much the other gentleman next door. And we like to pay respect to that and help work with these variables, various treatment options to provide options for other patients that seem reasonable to help them. And when I look at the options, I'm going to just say straight up, we have chronic pain, in which we have anxiety and depression. Having back pain for 3 months for one study causes 1 out of 2 people to have clinical depression. Not eating as well, not as happy, sad, crying uncontrollably. And anxiety and depression is not a cause of the pain, but a major symptom that we have to respect. Sleep disturbances. Imagine not being able to sleep because of pain. And this cycle, because you're not sleeping, you become more anxious and depressed, and your pain feels worse. Physical pain itself, the occupational challenges. You hear your patients say, I don't know if I can work tomorrow. I'm worried. This is my livelihood. Feeding into the stress, feeding into the sleep, causing the pain to worsen. This is not simply, hey, I need a doctor's note. We have to treat it seriously. The occupational challenge may change their whole life. And also just daily lifestyle changes. I can't see my grandkids anymore. I just have this pain. I'm staying home. I cannot go to church. We've heard this all because of this pain I'm having. And the treatment options we have include medications for depression, psychological personal therapies, exercise and movement always, more normal movement if we can, as much as we can, and changing sitting positions and standing positions as we move forward. Occupational and physical therapy for discussion of what you can do work-wise and in general at home. And certainly injections and medications and surgical options are out there. And they're options I have to offer as an interventional pain physician myself, but they're not the only options. If you look at the diagram here, it's a small portion of it. And I stress that we can all discuss these other options. A patient might say, I'm not depressed now, please don't talk about that. This is not all in my head. But certainly, looking back at the structure, we can calmly and politely say, well, it's not just in your head per se, but you feel this and I want to help you. And I think it makes sense to look at all these options. So treatment options. Where is there evidence for benefit with physical management therapy? Where is there less evidence clinically? HEP, a home exercise program with increased physical activity, easier said than done, with exercise therapy is the most effective in reducing pain in the long run and improving function. Walking can help acute pain, and there's a low moderate evidence of benefit. Heat therapy, putting heat to the area, shows some evidence of benefit in acute and subchronic pain, not chronic pain, but perhaps it's something that can help. And yoga, some benefit. Certainly, these treatments on the bottom, I'm not saying not to do it all. I mean, some patients still get benefit from what they say. But as far as the studies show, TENS units show only temporary benefit, no long-term per studies. Ultrasound therapy, again, not long-term, temporary. And temporary still is a big deal. And lumbar traction, stretching the back. There is a real lack of evidence from what I found in the literature on my searches. Alternative medicines. Alternative does not mean bad. Alternative means other things that we can use to help us. And certainly, with the Lord providing these other therapies out there as options, we want to investigate to say, can they help, and if so, to which patients and how much so? Behavioral therapy, cognitive behavioral therapy, has been found beneficial for chronic pain, chronic, years of this pain. Important to help identify the pain and correct the negative thinking. I don't think I can do this. My pain is stopping me. It's over. No, we have to try to change the tune on this, because there is always hope. To modify that person's response to pain, to help the neural circuitry that one has. And I'm certain out there right now, I'm talking to patients who aren't currently having back pain. You're feeling this back pain. You may have had it for years. And it's not just all in your head. I'm not trying to say that, but I am trying to say, hey, trying our best to modify our response to pain. And sometimes a neuropsychiatric professional with CBT can help. As far as chiropractic care, national guidelines have reached different conclusions of it helping and not. Acupuncture may temporarily benefit, but there's no solid evidence of long-term benefit. Again, massage therapy, prolotherapy gives some short-term, not long-term benefit. But short-term still, for some of my patients, even 1 day of benefit for this 10 years of back pain still means a lot. And I will not discount these therapies, but this is what the evidence shows thus far. Medications. Lower back pain can be treated with anti-inflammatories, muscle relaxants, opioids, antidepressants, and anti-seizure meds. And I like to use something called an NNT, the number needed to treat. If I have a perfect medication that treats 100% of patients with this condition, my number needed to treat will be a 1. If out of 10 people with a condition, only 1 person is treated, my number needed to treat is 10. So a lower number, closer to 1, is better. And when I treat with medications, I like to always look at what receptor is it treating? How does it treat you? That's why we can come out with a couple different medications to treat, be it a COX-2 inhibitor, a muscle relaxant working at GABA B like baclofen, or alpha-2 like tizanidine, opioids, which the CDC and myself included are not the preferred treatment for chronic pain. Please don't judge your patients and providers for prescribing it though, please don't. But truly not our treatment of preference for long-term chronic use, if possible. Working at the mu receptor. Antidepressants, increasing your serotonin and norepinephrine, more importantly, norepinephrine amounts in your body, decreasing the reuptake. And anti-seizure medications have been found to be beneficial, be it the gabapentins and pregabalins, working as voltage-gated calcium channel blockers. And I'm sure some of you have already been looking at these two diagrams, these charts on the right side of the screen, showing that for back pain and hip pain, the number needed to treat on opioid-naive patients is about a 1.5, quite good for ibuprofen and Tylenol. Morphine alone, 2.7, not as great. Oxycodone, 4.6, but if you add Tylenol, 2.7. Yes, I understand the gabapentins at 7.2 and the tricyclics at 3.6, but using the various medications as appropriate to help inhibit COX-2, boost your serotonin or norepinephrine, and block the voltage-gated calcium channel to help pain, these methods can help in conjunction together. We do have interventions and injection treatments, of which I certainly enjoy doing as a pain management physician, and I do these, but they're only one small part of the treatment options, and they're not everything, many of them temporary. But briefly running through epidurals, putting steroids in to the area where the caudate equina come out in the lumbar spine to help remove radicular pain. For the joint pain, the joints when they press back on each other when you lean back, to try to block and even burn, radiofrequency ablate the medial branch nerves and the lateral branch nerves of that specific joint. Sacroiliac joint injections where the hips meet the back to try to give some temporary relief. Temporary be it may, some relief can help them then the patient walk more normally, move more normally, and then get them to a place where now they won't depend on that. For conditions in which we have pain from the back down the leg that gain a neuropathic condition that seems more severe than it should be. This is what we call neuropathic pain, and we can certainly block those sympathetic nerves higher up the axis, close to the spinal cord. For those with what we call failed back syndrome, I'm not calling the back surgery a failure, no. Back surgery helps maintain and keeps from great detriment and damage happening in the future, but failed in that they're still having pain. And back surgery is not meant to cure all pain, no doubt. But when people still have pain, there are wires that we can place above the generator of pain to cause a kind of a TENS unit type activity to confuse. It's called trying to confuse that gate of pain perception such that 70% of patients with spine surgery who continue to have pain have been found on some studies to have up to 50 to 70% benefit of their pain. Not 100%, but certainly beneficial. And also the placement of intrathecal pumps of opioids that we need to refill on occasion, of course, and monitor, more purported for end-of-life cancer pain. Certainly, an intrathecal opioid pump will need to be increased over time, and supplementation with oral narcotics still are commonplace and part of the treatment too. Surgical considerations also come into play. I'm not a surgeon, but certainly obtaining a surgical opinion to make sure that I'm not missing something, as it's something that I don't do, I always like to obtain. And the three main types of surgeries I like to look at for lower spine include discectomies, partial removal of that disc, as they had been doing since 1938 with mixture and bar. Spinal fusions, when the spine starts to go down and the disc is being compressed, to fuse the vertebrae together to keep this from happening further, to keep from those joints in the posterior aspect from causing pain and damage too. And laminectomy. Laminectomy basically being the dorsal, the back aspect, this bone, the lamina, and releasing it to opening up that area to keep that area, that roof, from crushing on it and causing central spinal stenosis and pain and damage to those nerves. A laminectomy. Finally, moving forward, discussions of what else can we do to prevent back pain? And exercise has been found most beneficial in preventing back pain. And it's always tough. How do I exercise when I have this back pain? I've had back pain myself. Easier for me to say to somebody than to do it. But that's why we have all these other measures. Mattresses. What is the perfect mattress for this? And yes, actually, from my studies and from looking through literature, a medium firm mattress is much preferable to a firm mattress. It's not just get the firmest mattress, period. A medium firm mattress. And certainly the soft mattress is a great concern. I always say, you know, it's not that you have to really just get a new, completely new king mattress. I found for my patients, just get a twin size mattress for that person. Maybe have their spouse sleep on a separate twin size mattress or put them together. And I feel that the twin size mattresses have better integrity. And even putting maybe, is it being another blanket or a cover or trying to strut that differently and try to move positions, turn the mattresses around on occasion so that you're not stuck in that one lump on that mattress from damaging it. But certainly, I ask my patients to Get your regular regular Costco Sam's Club mattress, in which it doesn't have to be the special memory foam mattress, a smaller mattress, twin size, that they can use inexpensively, and try to rotate it on occasion to benefit them. Proper posture when sitting and standing is very important. And I'd like to say my own story is that I have been sitting a lot more since this past March at the same desk when discussing cases with my residents from my own room here on video, and discussing patient cases with and discomforts and various issues patients have had via video conference. And sitting in the same chair, I've noticed that I started slumping a lot more and sitting in a position that I started having back pain as of about 3 months ago. So posture, I began standing more, bringing my desk up when talking with patients, trying to sit more upright, and getting a chair that doesn't have as far of a dip. And certainly over the past month, I've done a lot better with just that change. For those handy or who like to work at home or with jobs, which requires lifting, proper lifting techniques. Please, please, please do not bend, as you see in the diagram here, with that posture straight down. Try to use your knees. And certainly it doesn't seem as natural at first, but if we keep trying to remember that, I think it can help. People ask about back belts, these braces that you use for not only working out, but for your back. Really, the studies do not show any long-term benefit for back braces. And if we're using back braces a long time, I found it to decondition a lot of my patients, and back braces are a big concern in my practice. I always ask them to please limit using them and please do not use it at all if at all possible. A lot of discussion through various patients have been the use of shoe insoles. And studies do not show any benefit from shoe insoles. Get a comfortable shoe that's comfortable for you, but for your back at least, shoe insoles have not been found to be of much benefit. So that will conclude my discussion for right now. And at this point, I'd like to open it up to questions that anyone would like to have for me. As you know, this discussion has been recorded, but I'm coming right back live, and I've been watching along with all of you thus far the past 30, 40 minutes as well.
Thank you so much, Dr. Pak, especially to bring this presentation for a condition that's so common. Even in the room that I'm in, there are individuals who are saying, I have that. So very common. Thank you for that. Couple of questions for you. Share with us, what are some of the common errors or weaknesses in I'm a primary care physician. So in the primary care evaluation and management of patients with back pain, chronic back pain, what are we doing wrong? What advice could you give us? How could we as primary care physicians improve in our management of chronic back pain before we send them on to you?
Well, thank you again for the allowing me to speak here, and very thoughtful, interesting question. In some ways, I pause when we talk about errors that other providers are making. And I'll have to say, as a human who makes many errors myself, it's very difficult for me to answer that question, but I will. I really think, at least from my 4 years here at Loma Linda, I haven't seen errors. I've seen different ways of treating. And every relationship of a physician, nurse practitioner, and provider to different patients, and even our own family and ourselves, varies. So I never think that there's quite an error, but the only thing I can say that may help a little bit more is to keep more of an open mind, and that if we're treating in one method, and I have to look at this every week for myself too, is there a difference for this patient? And for a provider to not say, well, this is what we do, that's all I do, to say, and I think it's okay. We're dealing with medical providers, people at the top of their class. When they're asked a question, it's got to be right. And I feel that way too. But sometimes the answer is, I'm not sure. Every person is different. If we have two people with the same problem, we treat them the same way. One will get benefit, one won't. We're going to work with the human quotient. Let the Lord do the healing. I don't do the healing, and move forward from there. I guess in a circuitous way, answering your question, I think the toughest thing is when we think we can cure it, and the frustrations that when we can't. And to realize, hey, we're help pushing along what's going to be willed or not to be benefit the patient, and that's okay. And for providers, say it's okay if it's working or not to work as a team. I don't think it's definite that you need me either in many cases. But if there's just an interest to try a different point of view, who may totally, you go back to the primary, you may disagree with me completely, and that's okay too. I say that too when I see a patient, but to say, hey, it's a team effort, and to work together and to look at it more globally, what other options we have.
I know that was a tough question, but I'm always trying as a referring provider, trying to improve my skills and trying to do better. So I appreciate your openness about answering that. Question, someone just sent a question in. How long should you immobilize minor compression fractures?
Well, a minor compression fracture, in many ways, the first question we ask a surgeon or myself, the orthopedist, neurosurgeon, is what is minor? And certainly minor can be graded different ways. Even for myself, not being someone who does a kyphoplasty, the surgeries involved, I pause. And immobilizing certainly is helpful. And you had my talk on the back braces, but it really depends on the patient and situation. And when this comes about, I think we need the answers from a spine surgeon. Certainly I could lean in on it. I think the therapists and physical therapy is a thought, but there's no specific number I would put on that myself, at least from what I've seen. Very different from what we may have seen 30, 40 years ago. But I think the tune is changing, and I'm not sure. And you'll have one surgeon say, and IR physician say, hey, we've got to intervene with a kyphoplasty, another, not at all. So how long? That's a great question. And I think it's really well thought out. The answer is we're not completely sure. It depends on the situation and patient.
Thank you. Next question. You touched on this in your talk, but maybe give a little bit more. The role of complementary medicine modalities. You mentioned yoga and acupuncture, chiropractic treatment, CBT, maybe CBD also, right? And then massage therapy. How do you, as a clinician, approach recommending or discussing these modalities with your patients?
So the way I approach it is that certainly I do mention toward the end of conversations that these are possibilities. And in many ways, I bring it up in that I've got to make sure the patient is with me on this, that we're together, and that they know I'm open-minded, because many patients have it in mind, and they certainly are afraid to ask a physician like yourself, Dr. Reichert, too, what about chiropractic? And to actually mention it, that I've heard that these things can help some patients. I think just like any medical provider, it depends on who you're seeing. You feel comfortable with them. Tell me how it's working for you. What are they doing? Studies do not support it as well in some regards, and we went through those studies, but certainly some patients have found great benefit. These methodologies are still here. With CBD itself, it seems like a bit of a hot topic. I would say it's very difficult for me to say it's okay or not with the fact that it's not as well controlled. So I pause on that. And even on the topic of various illicits such as THC being used, I say certainly California can say what they wish to say. I have a federal license, and I at this point cannot recommend that.
Thank you. And then one last question then. Give us some recommendations and techniques in reducing opiate doses that we see in some of the patients that we inherit. Patient comes to us, they're on massive doses of opiates. they still are in, fairly, high levels of pain on the opiates. We look at the literature and so forth and recognize that, this is probably something that needs to be tapered in some way, but very, very, very difficult patients in a position that now all of a sudden we have the role of taking charge of, their medication prescribing. So what are some recommendations and thoughts about, what you would do, and, what would you advise a primary care physician to do in those situations?
That's a great question, and I'm really glad that you bring that up, Dr. Reichert. Short answer, and if there's time, I'd like to give a little bit of a longer answer and my personal take and my experience even.
You have plenty. You have plenty
short
of time.
answer is really, as a provider, we've got to listen to the patient, have compassion for them, but then ask ourselves, what do we think the medication is doing to the patient or not? And the answer varies from provider to provider, and I think you're all correct. You say it's kind of okay, you say it's totally okay, you say, hey, no way. Those are all right answers, and let me go a little bit into the history, and in some ways, this is a talk in itself. In the 1980s and 90s, be it the powers that be, JAMA, the New England Journal of Medicine, would state that no one's getting addicted to opioids. But then we stop back, and this is the Bayer company's second medication. They made heroin. That's the second medication after aspirin. And they banned it in the early 1900s, only for it to come back, FDA approved, after various companies found a way to give it, such that by the 1970s, there's ads on Vicodin stating, this is your medication, this is your right, your prescriber can prescribe it with 5 refills, until recently. And I'm not angry about this. Business and the economic means help science and help patients greatly. But I find it interesting in that when I graduated medical school in 2001, and at the time of my graduation, it was a practice to prescribe, no issues. And I find it interesting that over the past 10 years, when opioids and the second and third generations became less profitable in America, JAMA and the articles that be, and even for myself wishing to publish, it became a lot easier to publish in a greater article now, recently, when it became less profitable. And I have to say, hey, you know what, it's just my take on it. And I have concerns, which can be argued against me, that long-term opioids decrease osteoblastic activity, basically meaning that slowly you can hasten osteoporosis. I have concerns of how it blunts hormonal milieu of DHEAS, testosterone, estrogen, to which people say, I can live with it, that's okay. I have concerns of the fact that I love the medication that has no ceiling effect. But when there's no ceiling, and we're talking about balance and really making man whole, I really love that term, making man whole. We have to make man whole, our fellow man here and ourselves. How do we give something that has no stop and that there's a need to take more? And this is not, some people have a higher predilection to needing something more than others. And you know what? I think we have to really not judge the providers who prescribe it, who say yes or no, or the patient who asks for it or who don't like it. I think that's where we've got to start. And once we have compassion for that, to really work with them to try to say, could we decrease it? What can a primary provider do? Is there a specific system going down to this morphine equivalent or that? I'm a little different than a lot of other pain providers. I don't think there's a specific number. I think 0 is the number I like. I have a catchphrase, and you've seen it too, this long 4-line thing of what I think of opioids, and you see it and you're like, well, he just copied and pasted that to my note. And in some ways, it's tough. It's disingenuous and so easy for me to do it. But I really, at least for me, what I do is I never say it's okay. I don't say your provider who's prescribing it is good or bad for it. I think they're still good. If they're prescribing, they want to help you. I do say, boy, I'm not going to say it's okay for your primary provider to prescribe it. I'm not going to say, all right, I've stabilized you on this amount. Go back to Dr. Riker. He'll keep prescribing it. I think that's wrong for me to do. That's passing the buck. Well, why am I passing the buck when it's someone's health? And in my opinion, the health-wise, it'd be nice to really decrease it to nil if we can. Not everybody can. There's patients in the audience right now who say, I'm on it. I understand how it works. Dr. Pack has it wrong, and guess what? For some patients, I probably do have it wrong too. We're all humans, it's so varied. But it's tough for the primary provider, any provider, when someone says, I need a medication, and almost more than any medication I've seen, how it brings such a response emotionally, positive or negative, how it makes you feel differently after you prescribe it or you don't, and they get angry at you. And I think that this response doesn't make me want to recoil. We have to hug it and understand it and not run away from it. And it may take, you may be the third provider who they yell at saying that why wouldn't you prescribe? Or to say you're the best, you did prescribe, and you wonder what you're doing with your practice, but do what you think is right and try your best. It's not easy. And the discussion will change over time.
Thank you for that. I know it's a difficult question, but you did a good job. One final question came in from one of our participants here. And the question is, what are your thoughts on lithium treatment? Are you familiar with lithium treatment in chronic back pain?
Well, certainly, my primary field is neurology, so I'm familiar with what lithium can do. I always love looking at the mechanisms of what these medications do. And as a neurologist, I look at the neuropsychological, and I do look at what it can do for cluster headaches even. True. And for back pain, certainly I can see what it can do. Certainly I have to pause for renal dosing and renal function. I have to pause and say, I'd have to look back and say, what are the pluses and minuses for different age groups? I don't prescribe it. I haven't in a long time, but I can see where it would work. Lithium specifically in literature out there right now for it, I don't know. I haven't looked at it recently. But I can see where you would think of that. Low dose naltrexone and various medications. What about even levetiracetam? What about topiramate for back pain? I've seen it. If it blunts the sodium channel, it blunts certain channels, I would say keep an open mind. And I'd say I'd have to look more into it. I can see where it could help. I'd have some caution on the medication though. Certainly research what other contraindication and concerns are out there with it. But that's a very thoughtful question too. This is a great audience. I'm having fun.
Well, thank you so much, Dr. Pack, for contributing your time and for this great advice about a very, very common topic. We appreciate your willingness to participate with us here. Thank you very much.
Thank you for having me, Dr. Riker. Appreciate you.